based portion of it on the cervical spine. And a woman from Queensland in Australia presented on the use of benefiting vestibular patients by accessing the cervical spine through manual therapy, as well as through some of the retraining and the reflexes and balance and all of that. And I was speaking with a gentleman afterwards that studied under her. And he and I were talking about how many people around us were like the little stars were going over their head, or like they hadn't ever thought about treating the neck in regards to these patients. And it's my first thought. And I don't know if that yields to my manual therapy background from the past, before I even got into vestibular. But it was just kind of striking to me that a lot of people aren't treating the neck, and they're just focusing on these exercises that drive so much from the cervical spine. And I was able to chat with her afterwards and kind of make some connections to find out more information and get some more research and some literature in that regard as well.
So what was her name? Was it Julia? Was it Charlevin? I just screwed her last name up. Charlevin?
Yeah, it's like Charlevin, I think.
Yeah,
mm-hmm.
And what did she present?
She presented on the cervical spine and the ways that she works with manual therapy and also does retraining prior to doing the vestibular exercises, like the gaze retraining, and some of the balance work, because so much of that comes from the head and neck. She touched lightly on kind of the inclusion of VBI concerns, as well as trying to remember back. Let me hold on. I have my notes here.
And again, certainly hypertonicity is going to be a common feature in any individual with vestibular dysfunction, I would assume. Eric, did you talk? I'm sure you talked a lot about the cervical spine as you did M7.
Oh yeah, pretty much spent the whole time on that, other than a little bit of shoulder girdle catch-up stuff.
Mm-hmm. And we're going to let her get her notes. No, it wasn't Jen. No, it wasn't Gwendolyn Jaw. I'll post her name. And I believe she does research with Gwendolyn Jaw in respect to it.
Yeah, I think you're right. Mm-hmm.
Yeah, I see their names on papers, and they're the ones they've looked a lot at, certainly all kinds of things from whiplash to, kinesiophobia, graded movement. So I think she also maybe co-wrote some of the book on chronic neck pain, or research summary that Gwendolyn Jaw did. I think she was one of the contributors to that. And that's what we look at is, what they're looking at is the ability of smooth pursuit, kinesthetic sense as being portions of this. So it's kind of really reintegrating that in that vestibular patient.
Well, and I pulled up my notes here, Dave. They were also she was talking about more teasing out what is involved in the neck and what was contributing to the vestibular system, and about looking at that head still body rotation test, but in multiple planes, like side flexion, not just rotation. And kind of just going over the evidence of using manual therapy. One of the things she mentioned was 50% of surgeries in the cervical spine had some connection to resolving dizziness. So just making sure that we're thorough in checking our patients, our vestibular patients, and we're not discounting the neck. And it's not kind of I feel like cervicogenic dizziness is the thing that we don't have any other answer, so we're just going to call it that.
Mhm.
And I think she did a good job of substantiating that a little bit more
Yeah.
in a group of more neural-based, probably vestibular therapists.
That is interesting because there's a large group. The people that originally kind of came up with Impact, who were at the University of Pittsburgh. I know some of them are not really big on cervicogenic dizziness. It's like I went to a lecture out there because they do an annual lecture in April, and it was Sue Whitney, and I can't remember the other person she commonly does presentations with was out there, and she was not a big fan of cervicogenic dizziness. So this is the vestibular conference is interesting on kind of because it all depends on where you come from in your particular biases. So that's why when you mentioned this, I thought, oh, well, that's rather interesting. Given
Mhm. And I who leads this entire conference. She puts it all together. So I like that it offers different points of view too. I mean, there's definitely a little bit heavy bias APTA wise, but I think they do a good job of kind of coming around to all sorts of different sides of it.
So just tell me a little bit about the body. Like they didn't just do body rotation. How did they do the other planes of motion?
Yeah, I haven't printed off those notes yet, and that was a week ago, so 2 weeks ago.
Gotcha. I
So
understand.
it's not as good in there, but I could definitely tease that out for you, Dave.
Yeah, I'd be curious to see that or get that up, just see what they were looking at, what their thought process is. And just to round it out, I mean, it could be congruent. Oftentimes you'll find whatever we're talking about, it's congruent in some way. It's just a matter of drawing the connections in what they're doing. Because if they're looking at that, then if they're trying to move the body without moving the canals, what they're doing, they're doing side bendings, the oncovertebral joint, are they fixing the upper cervical spine? I'd be interested to see what they were doing. Because then you can look at it biomechanically and think, okay, what are they thinking?
Yeah, and the other piece that she really mentioned with that was checking your smooth pursuit
Mm-hmm.
in neutral and right and left, so you get a better idea of what it's like, not just in the head forward position. That was another thing she mentioned.
Did they relate anywhere vestibular dysfunction causing neck pain, or was it more the neck causing the dizziness?
Looking back at my notes, it looks more at looking at clusters of signs and symptoms in the joints, in how the neuromuscular functions, sensory motor, and then looking at those clusters to identify more easily if you're treating cervicogenic dizziness or if you're just responding to the role of the neck in head movement and eye positioning and that kind of processing.
Okay. Good. Yeah. So yeah, nothing really kind of be interested to see what they have, but on the surface, nothing really kind of revolutionary. It's going to kind of change the course we've been on. But it would be nice to kind of look at that, get some of that information integrated. I'd like to see where they're thinking about it. But it's often what's old is new again. Like even the latest lumbar clinical prediction guide or clinical guidelines. Manual therapy was back in vogue again. After a 15-year off cycle. So hopefully it's coming back around the cervical spine.
I hope so. I think it plays a big role in it.
Did they differentiate at all the types of dizziness that people were dealing with?
Yes, they did, Eric. And it was very similar to what you discussed in the last module.
Okay, good. I was just curious how they're classifying that, if they were looking at vertigo versus, lightheadedness, et cetera, faintness.
More type 2, 3, not vertigo. Mm-hmm.
Type 3.
That was something I got more back from Jim, whereas it was kind of like the imbalance, the deconditioning, kind of the outside of the lightheadedness, more driven by the vestibular system or the neck.
Interesting.
If I'm remembering it right.
I think so.
These are good too. And it's, all these cases, Gwendolyn Joel did a presentation. I saw it on a podcast or maybe it actually been on YouTube where she addressed some of these things, talking about the cervical pain and being addressed. And she actually addressed manipulation. Talking about, begrudgingly that manipulation, what we do does work and relieves short-term pain and people feel better. The begrudging thing was she saw that muscle activation patterns don't necessarily change though. So if somebody has a upper ramp sternocleidomastoid or splenius capitis, that these dysfunctions tend to kind of persist, and that you don't semispinalis or longus colli capitis, which tend to be inhibited or atrophied, tend not to activate. So it's that idea that what these people need to not be chronic neck pain patients is neck strengthening. But how many of our neck pain patients ever do 26 weeks of neck strengthening to improve?
Never.
Yeah. So there it's
26 weeks.
Yeah, it's easier to come back in every 26 weeks and get remanipulated than it is to do 26 weeks of exercise. But that's often kind of what we're looking at to a degree. So the exercise portion does have a huge amount of value in retraining. Pain modulation as well in the short term, and doing these exercises, isometric muscle activation, and then giving them the strength progressions is important, but they probably will not be sticking around long enough to actually see the fruits of the true hypertrophy. Cool.
Dave, as I look through it a little bit more, she kind of touched more into like afferent training. And so using the manual therapy as a neurophysiological approach to decrease the deep muscle inhibition that typically comes with those types of postures,
Yeah.
and decrease the dependence on like more of the superficial muscles, and just position the head better in space for the vision to give the communication and all of that, drive that, which I thought was interesting. Think about that.
Yeah, and that's that approach that and Joel Bolosky, again, certain groups will push it. There's a neurophysiological benefit to manual therapy. All of us use it. I use it. There's also mechanical. And she may be emphasizing that neurophysiological because it's more in vogue to talk about that in manual therapy circles than the mechanical. But by now you should have noticed that there is certainly a mechanical effect. And what we should be able to do is be able to tease out, when am I doing this? And this is more of a neurophysiological technique versus a mechanical technique. And your outcomes and your end feels and those things should all help you determine when am I getting one versus the other. I think your neurophysiological techniques will be short-lived without changing other patterns. When they come back, they'll be exactly the same, unless you change the trigger. Mechanical ones come back, they should be 70, 80% better with some cleanup work needed, or the strengthening pattern now being the point that they need. So my initial question to them as they come in is, your pain was better afterward. How long did it last? Oh man, I'm still good. I'm like 70% better with a little bit of soreness. I'm comfortable with mechanical. I felt good, but by the next day, the day after, my pain was kind of back and it was the same neurophysiological.
Yeah, it's kind of a good way to look at it. I don't know if I've ever thought about it from that perspective, but makes sense.
Yeah, so that's kind of my gauge on, okay, where am I and how much am I getting? And if the joints resublux, then I have something jamming it there. And maybe I'll manipulate it again. Usually something I'm uncomfortable with. I'm not doing something, scary or dangerous.
And I think the automatic assumption is when you have that patient that comes in and, for a second visit, a follow-up visit, and they're like, oh, I was pretty good for 2 days and now it's kind of back. You just assume that, oh, I have to, go back and redo the same things that I did the last time and hope it sticks better,
Mm-hmm.
Maybe modify the exercise program. I think that's kind of the default that a lot of therapists will get. It's just like, well, I was on the right track, but maybe I'm missing a little something, or maybe I just need to redo things, and it takes time to get that back together rather than looking at it from a mechanical versus neurophysiological perspective. That's an interesting way to think about that.
Yeah, that's kind of the screen I'll use, and just see that just shows me, do I need to pivot directions? And right, it's restuck, then I know, okay, there's something else going on that's sticking it. And I can get the benefit. I'll take full effect of the manipulation to get them better. But then I need to kind of also dig a little deeper in other areas and see the neurophys portion of it. Or if it's the neurophys, then I know that, okay, neurophysiologically, this is up ramped. I need to look at neurophysiological techniques that'll maybe better hands. That person would do well with dry needling. That's the one that does better with dry needling. The dry needling one comes back and goes, yeah, I felt better for a while. I felt really good, but boy, it's kind of back now. And that's the one where they get the pure neurophysiological blockade, as it were, whether it's a serotonin release down that spinal segment or is it central opioid, facilitation, but then their symptoms come back.
Yeah.
Cool. Looks like we will have time to torture somebody.
Yeah.
Let's spin the board. Who are we going to torture?
We just torture Jenna again. That'd be funny.
Oh, Jenna, you out there?
I'm not saying a word.
Okay, the person right above her. This is kind of funny. It's like the Hunger Games. Who's going to win the lottery? All right, Christian. Christian, you up?
Can you hear me?
I can. How you feeling today, buddy? Feel lucky?
Not lucky, but I'm here.
Anymore.
Nah, this be fine. I was thinking plantar fasciitis today. Or well, I'll give you the diagnosis there, so that's not really fair. Let's call it, I have a patient that's 30, let's say, I don't know, how old do you want him, Eric?
We're talking heel pain.
Heel pain.
Let's do 42.
Okay, 42-year-old male with right-sided heel pain. So first thing in your mind is, what is this? You haven't even seen this patient yet, Christian. What's your what do you think as far as like differentials that are most likely for this individual?
Well, we'll say plantar fasciopathy. I'm sorry, plantar fasciopathy. Whether that's plantar fasciosis or fasciitis, one of those.
Okay.
Let's go with stress fracture. And can I say some sort of like biomechanical or segmental dysfunction?
Sure. Sorry, I'm trying to get a list up here so I can list them out and post them. So what was your first one?
I'll say plantar fasciopathy.
Okay. What would this look like?
The plantar fasciopathy.
Let's say you said two different diagnoses.
Mhm.
You said itis and osis.
Correct. So with the itis, I know that with the patient, he'd have more pain in the morning, pain with each step as he's walking. And then with the fasciosis, I know for that it'd be kind of stiff when he's walking, but then as he's walking, it kind of loosens up, decreased pain throughout the day.
Okay, so I'm still trying to get my list up here. What else do we have? Anyone else like to chime in? Is there anything additional? What is your itis and osis list?
What about severity of pain?
More pain with the fasciitis.
Okay. So this individual, let's say they have, they have pain when they weight bear. Let's go over the different ones. What else did we say? What was next on your list? Sorry, I'm trying to write it down.
I said stress fracture too for that.
Okay, so what would you look for in a history of stress fracture?
It's more so if they've been increasing like any sort of activity level, like let's say he's like a runner and increase the activity level with that. And
Got that the first time.
I know.
What's the pain like?
More like I want to say like a sharper pain.
About the onset?
More like an insidious onset.
Well, yeah, but plantar fasciosis and fasciitis could also be that way. So how does that differentiate for you? There's a particular component or particular description of pain onset with stress fracture that's more diagnostic of a stress reaction.
Would be more like gradual.
Yeah, progressive. Because if you think about it, when you're looking at somebody that's, if it is, you know, say a runner, somebody that's increasing their activity levels or, you know, changing something about that function, particularly a weight bearing function, that's going to be an insidious, that's not necessarily going to be an insidious onset, right? That's something where they've actually made a change, right? Some insidious onset is when nothing has changed and this pain just starts to come on. If that makes sense.
Yeah.
So in this case,
Kind
if
of
you said
technicality,
it's
but-
insidious onset, would that strengthen or weaken stress fracture?
Insidious onset would decrease my suspicion of a stress fracture.
What would increase your suspicion?
Of a stress fracture or the,
Stress fracture.
I thought we said just the progressive gradual onset of her pain.
That would increase your suspicion of stress fracture?
If we're saying that she's had it, well, I guess the pain's kind of gradually increased, then I would say stress fracture. And then if it's more of an insidious onset, then I'm going to say some sort of fasciosis or fasciitis.
And I'm a little confused the differentiation you had on that one.
I missed
Yeah,
in there.
Yeah. With this one, let's say what would a runner, okay, she's got a 42-year-old, okay, 42-year-old male. Okay, he's running. What would the pain pattern look like if it was a runner? What do you think it may look like if this is a stress fracture in a runner? How would they describe it? Yeah, and you can give two patterns, and I'll give you the first one. The one pattern is all at once, and I couldn't run anymore, but you can't pick that one because I just said it. So what's the other pattern?
I have no idea, to be honest with you.
This is tough, isn't it, Christian?
Yeah.
The other pattern. Think about stress reaction in bone. Think of this minor fissuring. You get stress, and the bony matrix changes a little bit, gets denatured, and then you go back and run on it again, and it stresses a little bit more, and now it becomes slightly symptomatic, you know, and you kind of feel it. It's vague, but then you go out for that 10-miler or 15-miler on the weekend with your friends, and this thing just becomes severely acute after a certain point, and now you can't run on it. So you'll see oftentimes stress fractures progress in this manner. A common one would be neck of the femur in the 40-something-year-old female, where she can run on it for a while and she notices, but then she reaches this tipping point as this bone starts to fracture a little bit more and you get more bony changes and it fails. So sometimes you get that progression that can occur. You see that again with, you're trying to differentiate shin splints from stress fracture. You know, seem fairly similar at a time, but they can be, you know, the stress fracture then just completely shuts you down. It's not superficial, it's deep, it's in the bone. It's a different feel, it's a game over. And you can see that. And sometimes it happens later that you have the stress reaction, you have the stress fracture, they modulate the pain while they're running, but then afterward, then the pain builds and builds and builds, and then they're sore for a while, then they try and go out and run on the sore leg, and then they can't run on it. That I've seen too. Any other patterns, Erica? What's your typical pattern that you would see, whether it's heel, shin, or hip?
Well, I mean, as far as just the generally for stress fractures is usually they present over a progressive period of time. You know, somebody will tell you that, yeah, I've had this issue going on for 6 months, but I've been kind of getting through, I've been managing. And then, you know, like you mentioned, we had this one particularly difficult training session, or I had this one particular incident, and all of a sudden things are just really miserable. Can't walk on it, certainly can't run on it. So that's probably pretty common. Now, as far as differentiating between fasciosis or a plantar fascia issue and a stress fracture, there is actually one other thing that you could very specifically ask the patient about onset of pain during activity. Okay. Christian, do you think you can figure out what the difference would be? When would the pain be more acutely present?
For the fasciitis, wouldn't be in the morning.
No, I'm talking about with the cycle of running or with the cycle of walking.
Gotcha.
If you think about, we did a particular stress test for the plantar fascia in weight bearing?
What is it, the windlass?
Yeah, so what position of what stage of gait would be painful with plantar fasciosis or plantar fasciitis then?
Like a mid stance then?
No, because think of the test that we did. What did we have to do to the foot?
We have to raise up the great toe.
Yeah, so what phase would that be?
Oh, push off.
Yeah, heel rise, right?
Yeah.
And what phase of the gait cycle would be worse with a stress fracture?
That would be like, would that be mid stance then or no?
It'd be more heel strike,
Heel
right? As
strike,
soon as the
okay.
weight comes down on it, right?
Gotcha.
Yeah, injury rates in runners are strongly correlated to the vertical loading force. It's the initial ground reaction force, the curve. If you ever look at a gait curve, there's a spike when your heel hits the ground, and how vertical that curve is, how fast the force comes in the body correlates directly to lower extremity injuries. That's why midfoot, forefoot running tends to have a little better number sometimes, because if I hit the ground and I'm progressing my weight faster to the midfoot, forefoot, that curve softens, and that is basically correlated to decreased injuries in runners by softening that initial vertical ground reaction force of the heel strike.
Yeah, and it's not just the vertical force; it's that there's a horizontal momentum force that's affected there as well. And I think we most of the things that I've read tend to associate that into the vertical force, because that's essentially the ground reaction. But the momentum coming forward, if you heel strike, right, your heel comes down first, essentially what you see in some of these graphs about force vectors is there's this abrupt drop in the patient's forward momentum, right? And so it's basically they're coming to a complete stop, having to go through that rockering motion and then re-propel themselves. So when you're coming down on the forefoot or the midfoot, you're essentially loading elastic tissue, right? So you're loading more the joint capsules, the ligaments of the foot, loading more of the Achilles and some more muscular tendinous structures. And so you get more recoil out of that. And it helps maintain some of the forward momentum better than it does when somebody is a heel striker. You've probably heard that same sort of stuff, Dave, I imagine.
Yeah, absolutely.
But that's a good way of looking at, just another thing that you can ask a patient. It's just like, well, does it bother you only with running or does it bother you with walking? Okay, it bothers me with both. Well, okay, so does it hurt worse when you're pushing off of the foot, or does it hurt worse when your heel is striking the ground? And if they say, well, it's more with heel strike, yeah, that's going to lean me more toward that stress fracture, especially with the progressive onset, more severe pain. And somebody that has had a change in either training volume or time on their feet, things like that. So that would push me more in that particular direction, versus if they say, no, it's really hurting worse when I push off and it's more early in the morning. Okay, now I'm leaning more toward the soft tissue injury, like a fasciosis, something like that.
Okay. What other differential did you mention? And anyone else?
Sorry,
Go ahead. I kept talking over you. Sorry.
No, you're good. I said fasciosis, but I know there's like the fat pad atrophy too. We could potentially realize or guess, hypothesize.
What would fat pad atrophy typically look like?
I know with that, I believe it's like also again pain on every step, and then isn't there like the phone's ringing right now. The calcaneus, can you palpate it through the pad? It's pretty tender there.
Yeah. I mean, that would be your test, is you feel a diminished fat pad is what you would end up seeing. And again, in 42-year-old male, maybe if I had the right age group, I'd look for something that caused the fat pad atrophy, aging, obesity. Those will be things that'll do it. What you may see with this is a variation of this. And Jim talked about this in one of the cases he gave you, and it's like a pain differentiation. It's actually somebody I have right now who was diagnosed with plantar fasciitis by the podiatrist, had it injected, had orthotics made, and he came to me kind of about a year later, and his pain is lateral heel. He has restricted, again, first ray extension. His first MCP joint cannot extend. So what that has done is that because he does not want to load his first ray, his weight in stance lingers longer laterally. He inverts his heel and he keeps his center of mass. His body weight doesn't roll lateral to his foot, and then through the first and second ray, that motion is delayed. So he keeps his heel inverted, which subluxes his subtalar joint. And what it does is it kind of pinches off the lateral heel. So you get compressive force that's high between the lateral heel and the fat pad. So he gets a soft tissue irritation there. And that's what Jim talked about. It's a bit of fat pad irritation, or not really atrophy at that point, though it can be focal atrophy because of his foot mechanic of not wanting to weight bear through the big toe. He's driving all the weight through that lateral foot. So it's not actually plantar fasciitis. He's got more of a fat pad irritation due to the asymmetric and prolonged loading on the lateral heel. Does that make sense? And it's the etiology is an unwillingness to roll his weight to his big toe. So just to tie it back to a prior case, Jim, you may see this fat pad atrophy, but as you look within the heel, it's not always plantar fasciitis. You can see these variations based on the biomechanics of the foot.
Yeah, there's a few others that are pretty common too.
Mm-hmm. Again, other differential. We have fat pad atrophy, we have ligament fascia, we have stress fracture. There's no nerve tissue in the foot, is there? Is there any nerve down there? Christian, still you, buddy.
Oh, sorry.
Are there nerves in the foot?
Yeah.
Good. Are there peripheral nerves in the foot?
Yes.
Good. Are there is there innervation coming down from higher above in the foot?
Correct. Yes.
Good.
So are you trying to make this like a L5, like radiculopathy, or?
Yeah. What would that look like?
So for L5 radiculopathy, there would be I'm blanking on the weakness. Oh my gosh. Will either be weakness of the dorsiflexors, and that would be a fatiguing weakness. There would be potentially decreased sensation and decreased reflexes. So it would be
more of a paresthesia or dysesthesia. Sensation could be iffy. But yeah. What would your biomechanical exam look like in your scan exam?
for lumbar or for the foot?
For the foot.
For the foot. I mean, he's saying like how I would take them through. I mean, when I'd like.
Well, what would you find in the outcome? You've done it. What did you find?
Are we still going for radic? Are we going for like?
If it's a radiculopathy from the lumbar spine.
What I would find weakness of the. I said weakness of the dorsiflexors. I would find.
Maybe a little more specific. Would there be any pain?
With the radiculopathy.
Scan exam. Would there be any pain?
Potentially.
What type of pain?
Because that would be more of a electric glandullating pain.
Yeah, I mean, if you could see that if it's a neuropathic pain. What might you get if it's more of a radicular pain? Lancinating causalgic being that neuropathic ectopic firing. If I have low grade compression, more of the things you said before, you get more of a paresthesia, dysesthesia. Do you get an increase in those symptoms, or do you get a shooting pain that goes down the leg? Is that lancinating pain from the ectopic discharge? So you look for that. Now, how would that differentiate from peripheral? So now you're getting these symptoms, saying, man, how do I differentiate central pain from peripheral pain? How would the two look different on the exam? Describe peripheral pain. or peripheral neural symptoms. The easiest thing to do as you do this is just think about, okay, let me just describe what does peripheral neuropathic symptoms look like?
With the peripheral symptoms, I mean, I know for the radiculopathy would follow more of a dermatomal pattern, and then the peripheral is just going along the whatever nerve you're searching for.
Yeah, you're gonna see that if they have loss of sensation. How is the loss of sensation different peripherally versus with a radiculopathy or a central or a peripheral compression at the nerve root?
It follows the dermatome. So like, I know like you're looking for like a specific phrase and just like.
How do the nerve fields differ? So if I clip a peripheral field, it's going to be very discrete lines because you don't have the overlapping innervation per se. So many times it should be very discrete, very focal. So if I cut a peripheral nerve, there's an area of anesthesia almost versus an area of dysesthesia or paresthesia. So peripherally, do it. Now the ankle's a little trickier. There are a couple nerves around the ankle joint that can get irritable and give you ectopic firing, and and they can be conditions usually along the heel. It's like there's a lateral cutaneous or lateral branch of the sural, and then there's a branch off the tibial nerve medially, and that can give you some medial and lateral ankle pain that'll go down to the plantar surface of the foot or down into the foot. So you can see some neural cases that way. But it's you get sharp shooting pain. You have a negative exam if you do a biomechanic. Let's say you're looking to do an exam, think it's plantar fasciitis. Your plantar fasciitis exam comes back negative. It'd be a neural tension test or some type of stress test. Or you look for the provocative position that causes the symptoms. Take them to the task that is the problem, then evaluate the mechanic. Anything to add to that, Eric?
No, not really. I mean, one other thing that you have to consider with peripheral nerves is they don't. One of the structures that can actually produce the neuropathic pain is sensitization or irritation of like a chemical irritation of the dura. You got to realize that peripheral nerves don't have that, right? So that basically ends at the intervertebral foramen. So it's really difficult for peripheral nerves to produce neuropathic pain in general. It really requires an immense amount of inflammation and probably a lot of repetitive friction for those sort of things to happen. Like if you think of like an ulnar neuritis, that sort of thing, it really requires a pretty significant inflammatory process to get the epineurium to be as sensitized as what the dura would get. So, I mean, that's just another thought process, but I agree with most of what Dave was mentioning.
Cool. So
maybe one other thing that I would want you to kind of take a thought of, Christian, as far as a differential here. So you've got plantar, you got the fascia, right? So connective tissue, you've got bone, you've got nerve. What else could we have? You mentioned the fat pad.
Joint.
Well, there's no joint on the bottom of the heel, right? We would tend to have that more on the inside of the outside of the foot, where the actual joint line is. What else do we know attaches to the heel in various places? Krista's got it.
Oh, tendons.
Yeah, right. So some sort of tendinopathy, right? There's a lot of intrinsic muscles of the foot that attach to the calcaneus. And this is what well, first of all, what might that look like? How would that present as like what would the cluster, the pattern look like for a tendinopathy around the heel?
If I were to do a contractile test, that would be positive, pain with palpation.
Yeah. Those are probably your two biggest things. Now, the hard part with those two things, or at least especially with palpation, is there's so much tissue on the bottom of the foot, right? It's difficult to just differentiate what structure you're exactly on. Versus looking at something like in the elbow where you can be pretty confident that you're over the tendon itself versus being over the fascia, being over the fat pad, any of those other soft tissue structures that would be in there. But the resisted test would be a good one, right? So here's where some of this stuff comes in, is if we have somebody that comes in that has difficulty with loading the foot, right? Whether it's problems with subtalar mobility, creating increased load through the midfoot, right? So now we're getting all of that loading going through the midfoot where the rear foot's not able to contribute to that. Essentially, when we start to get that sort of thing, what's one of the major structures that's going to start to help with that, right? So we're going to load the plantar fascia more, but we also may start working harder with those intrinsic muscles in order to try and help to support the arch and create that elevation and protect that from dropping down too far, right? So that's another issue that can come into play quite a bit. I see it a lot where patients will come in and say, oh yeah, my doctor says I have plantar fasciitis, and I ask them to point to where their pain is. One of the first things I'll ask them to do, and they'll point right to the inside of the heel, right? Almost to just the very front medial edge of the heel. And that's not really where the plantar fascia attaches. That's going to attach more to the middle, kind of the medial, middle portion of the calcanea, the anterior tubercle there. But that middle calcaneal tubercle is where a lot of the intrinsic muscles of the foot attach, right? So that's an issue that we see quite a bit, where it's essentially caused by some of the same issues, but the actual structure that's being damaged is different, if that makes sense. And it can change some of the treatment techniques that we may use, right? Because for plantar fasciitis, we're going to try and do what we can to help alleviate the increased loading stress that you're getting through there. But some of the secondary things, like with a tendinopathy, we may do things like pulsed ultrasounds, we may do things like cross friction massages, things like that would actually help with healing those structures that we may not do the same with a plantar fasciosis. Okay, so being specific with the diagnosis between those two things, even though they're caused by the same issues a lot of times, can be beneficial because it may affect your overall treatment. That makes sense?
Yep.
You with me on that too, Dave?
Yes.
Other issue with that medial calcaneal tubercle is a lot of people will end up heel striking there, right? Because we should heel strike on the lateral calcaneal tubercle on the outside of the heel. But if somebody has issues with maintaining hip alignment, right? Say they have a EUFR issue where there's hip external rotators have become a little inhibited, and suddenly instead of their heel striking at that 35-degree angle we talked about for the subtalar joint, now they're striking more neutral or maybe even a little internally rotated, and they're suddenly coming down on the medial calcaneal tubercle. We'll get a nice tenoperiosteal irritation of that structure because it's just not designed to take weight. So again, etiology tends to become very important when it comes to that sort of stuff, because that would be something we'd be looking for higher up the chain and not local to the foot. All right. Do you have a diagnosis for him now, Dave, that we've kind of gone over the patterns of each?
Let's keep it simple. We'll go plantar fasciitis, but let's really get into just a list of what potential etiologies for this could be. We don't need to go into detailed discussion on each of them, but let's start paraphrasing kind of, okay, what are the things that we would look at, or where would we consider this kind of moving, we can go from the foot up, what we may see. Christian, first, what possible thing would you see in the foot that could drive this?
There could be, I look at the subtalar joint, how that's moving. If it's stuck into inversion, is that
a question?
Both question and answer.
Question and an answer. It's very existential of you.
Mm-hmm.
But I would look at the subtalar joint and see how that is moving. If it's inverted, that can
How does that increase the stress on the plantar fascia? It's just a
Um,
question, simple as it is.
mhm.
Just stuff
Um,
it won't evert when we're kind of rolling over it.
mhm. So since it's not everting, the the I want to say that the foot intrinsics would have more stress on, or the plantar fascia more stress on there as you're going through the as you're walking.
Well, so think about it, right? So what is the foot supposed to be doing as the heel is everting? What is the rest of the foot supposed to be doing? So we're past heel strike. We're into stance phase now, right? The foot has kind of dropped, forefoot has dropped onto the ground. Okay, and we're starting to transfer weight coming over the top of the ankle, moving toward ankle dorsiflexion. And so what else should be happening at the foot at that point?
And the foot should the medial foot should invert and then laterally rotate, correct?
Yeah, and this is complicated because we haven't been through these mechanics directly, at least not in real big depth. Jim will go through a lot more of this in module 8, but we should be getting the foot flattening out, right? So if this is the medial foot, then yeah, we're going to get, that's an inversion with lateral rotation, right? And then we're going to get some abduction going along with that. Lateral foot, right? It's going to evert with medial rotation and abduction, right? So the whole foot should be flattening out. So if you can't do any of that in the rear foot, where do you have to take up that slack? All the joints distal to it, right?
Yes.
Yeah, I mean, it's not going to be one specific joint, although the talonavicular joint will take a rather large brunt of that. But essentially everything out has to flatten out more in order to still absorb your body weight and deal with the ground reaction force. So all of that increased pressure going through there will add more load going down through the plantar fascia. Now that's if this is a restriction of eversion. Do you think it's possible to have fasciitis if you can't get into inversion?
Yeah.
Okay. Can you reason for me how that would happen?
Trying to think of the opposite of that. So
Let me ask you this. When is the
Go ahead.
plantar fascia the most stressed?
in toe off.
Toe off? I think you're one step too far.
We'll say when the foot's flat. No.
So it's at the moment right before heel rise, right? When the foot is completely flattened out, and then as we start to lift the foot, when the windlass mechanism starts to go into effect, that's when it's going to have the most stress on it. So the thing that happens when the heel rises is the heel should invert, right?
Mm-hmm.
So if the heel can no longer invert, there remains an excessive amount of tension on the plantar fascia, right? Because now the heel can no longer swing into that inversion swing, right, with heel rise. So if you think of that plantar fascia, it's pulled tight, right, as we get through stance phase, we're going toward heel rise. And then all of a sudden, what should happen is the heel should invert and allow a little bit more slack, right? But all of a sudden, now we have this heel that's stuck like this. Now we're lifting the heel, increasing the windlass mechanism by getting into first metatarsal extension. So all of this tension that we've built up remains through that beyond the stage that it's supposed to, if that makes sense.
I'm still trying to like envision it.
I mean, essentially, when the heel goes into eversion, full eversion, we're going to increase the amount of tension on the plantar fascia, right? We're going to take those two, we're going to take the heel, it's going to evert like this, and everything else is going to flatten out, and so it's just going to stretch that plantar fascia like so.
Gotcha.
But if this thing can't invert to take those two insertion points closer together and provide a little slack, if this is stuck like this, and then we increase the tension by producing that windlass mechanism by going up on the toe, all that we get is this continued excessive stress on the plantar fascia beyond the stage where it's supposed to be absorbing that stress. Right. So now it's doing extra work at that point.
I also think because at that point, you've not really moved back into what they consider the resupination phase. Where, you know, if the joints then are locked, you're transferring load through the articular structures. Whereas in that position, now you're right, plantar fascia and other structures have to absorb more of the load, or at least tension out, to then transfer load.
Yeah.
Or it's just you're going to leak energy.
Well, and so what's another compensation that the patient may have? They may roll over the medial side of their foot, right? They go over that first metatarsal MTP joint because now they don't want to go into that toe extension because it's increasing the amount of stress on the plantar fascia. So they get a secondary issue because now they're getting increased friction going across the first MTP and across the sesamoids that run underneath there. So there's a lot of stuff that can come out of that. I mean, essentially, when you go from terminal stance, right? So terminal stance being when you're in full dorsiflexion, but the heel has not lifted off the ground yet. The foot should be flat, right? We should be in a flattened foot position. As soon as the heel rises, we should get the foot to twist, right? And go into a twisted position. But if you can't get the rear foot to do its portion of that twist, something is going to have to compensate for that, whether that's from a load perspective or from a mobility perspective. So if you're dealing with a sore plantar fascia, well, it's a vulnerable structure at that point. Keeping up with this? Anybody else have any questions about this? No? Okay. So let's get away from the subtalar joint just for a minute. We only got a couple minutes left here, but what else could cause problems?
It could be from the hip.
Okay. Let's go there. What's the hip doing? How's it affecting the foot?
If you are doing like a extension hypermobility, you could have a long leg, right? And that could put more pressure on there as well.
Yeah, so you get a leg length discrepancy. And again, this is something Jim's going to go into quite a bit. So essentially what happens is now you've got these two vertical limbs, right? And one's longer than the other because the hip can't extend, right? So where do you have to take up that stress, or where do you diminish the leg length? How does the body even that out? By flattening out the foot, right?
Right.
Yeah, so that could very easily be a problem. Dave's giving you some run time here, giving you some other answers. Where else could we go?
Stick with the hip. We won't even make it to those. We'll fill those in online. I'll put that up as a wiki. You guys can fill in the other ones. Let's stick with the hip.
Okay.
Minute left. Yeah, we got subluxation, and then think about uncontrolled motion of the hip. If the hip is not well controlled, and the speed of internal rotation, is internal rotation controlled? Is it happening fluidly? Or if it's not, what is then the stress factor on the foot? So you definitely have to look at the femur, one being subluxed, but 2, are the biomechanics in gait and/or running normal or abnormal? And how does that impact the forces as they drive down into the foot? So we have the subluxation of the hip. Give one hip mechanic that would potentially also create plantar fasciitis if you're watching them walk.
Didn't we see the lack of extension at the hip? You asking for another one?
Lack of extension, or I would say lack of, if you have excessive femoral internal rotation. So you don't have the, it's also used termed the abductive, but you have internal rotation if it's not controlled. So during it is increased pelvic rotation, probably pelvic drop, or the hip abducting or adducting as you run. A lot of these different factors will create rotary moments in the foot and drive it down into the foot. So we have the subluxation, but then we think beyond that of what's happening dynamically at the hip. Is the muscle timing, and they're also doing it. There's research, going into the sick and lower extremity, gastroc length, they look at a lot as being a causative factor in contributing to plantar fasciitis. Now, we can look at a lot of things with that. Is it neural tone? Is it a sublux subtalocrural joint, which we didn't have on that lower list, but would be there in your biomechanics, but also within the hip, you have that as well. But I think what we may have to do is just pick this up next time. I think we are.
So spend a little time over the next week and look up at these. If Dave's going to get this out to you guys, look up some of these other diagnoses: bad pad atrophy, peripheral neuropathy, radiculopathy, and start thinking about some of the etiologies that can cause that, and specifically what you might be able to do to test for those particular etiologies. That sound doable?
Yeah, I'll post this. Like I put the others we did last week up in a wiki on. It's called a wiki on the page, on module 8 page. You can go in there and edit it. So I'm going to put this document up there, and you can go in there and you can put in what are your thoughts or what are the differentials for each one of these. You can essentially build out a practical exam. So if none of you do it, then none of you get it. But I recommend all of you go in there, take a look at it, add to it where you feel strong. You can avoid the sections where you may not. Be bold and go after some things, because we'll look over it and see and correct things. So don't be afraid to be bold, but go in there and complete these, because this is incredibly valuable in your time leading up to Jim. And that said, Jim wanted to go over those questions that he posted next week. So Jim, next week, he posted 3 questions on the board. He'll go over those next week as well.
Yeah. All right.
Cool. All right, guys. I'm on to my next meeting.
Yeah,
Good.